Translational Research Interest Group call. This is Elizabeth Cohen from Hunter College, and I just want to say that we'll be getting started in just a few minutes with Dr. Betty Beckemeyer from the University of Washington, who's going to talk about practice-based research with local public health systems to improve health. We're just going to give people a few minutes to log on, and we'll get started at just about 3:03. Thank you, everyone, for joining us. It's a beautiful afternoon in New York, so I trust that it's a beautiful afternoon everywhere. I want to remind people to mute their phones and also that the call is being recorded and archived on our YouTube channel, which is the NS-TRIG YouTube channel. So we are so grateful for everyone to come on to support these calls, and we're doubly appreciative of Betty's time in preparing and presenting for us today. So I'll give people just another minute or two to log on and we'll get underway. People are still logging on, so I'm going to give them till 3:03 to come on to the call. Again, this is Elizabeth Cohen from Hunter College, and on behalf of David Banks and myself and the people at NINR, we feel very fortunate to be able to present Dr. Betty Beckemeyer, who's a professor at the University of Washington and who, I'll say it again in the introduction, but who taught me about, who coined the word pracademics for people who are both academics and in practice and thinking about how we practice. So we're thrilled to have you here today and for everyone who's on the call. And I'll give people just another few minutes. The list is still populating, so I wanted to give people a chance to log on. So I'm going to do a little introduction. We welcome you to the Nurse Scientist Translational Research Interest Group call. I'm delighted and grateful to be joined by Dr. Betty Beckemeyer, who's a professor at the University of Washington in the School of Nursing and the director of the University of Washington School of Public Health's Northwest Center for Public Health Practice. And as I was saying, she introduced me to the word pracademic, and I've been using that and thinking about that concept since that time. As a distinguished public health systems researcher, she's focused on improving the effectiveness of our prevention systems and workforce. She's led many studies in partnership, really, with local health departments and local health services and tracked their impact on health incomes and disparities. She's the PI of the Public Health Activities and Service Tracking Study, initiated in 2010, and today that study is a highly regarded growing database of uniquely detailed and linked data that links public health services to health outcomes, and it has supported several interdisciplinary studies. Dr. Beckemeyer's studies on change, variation, financing, and outcomes regarding public health systems are conducted in close partnership with public health practice leaders and have been relevant in addressing current policy issues. Her efforts in guiding a generation of evidence and data to support public health practice improvement include the development of a dissemination and implementation model aimed at facilitating uptake and integration of standardized local public health services and financial data into state and local systems. She's a national nurse leader. She's a fantastic colleague and friend. And just as a reminder to everyone on the call, please mute your phones, and the call is being recorded and archived for the YouTube NS-TRIG station. So with that, I'm going to introduce Dr. Betty Beckemeyer. She has served in significant leadership positions, including the American Public Health Association, the American Academy of Nursing. She's a Robert Wood Johnson Nurse Fellow. And Betty, I will turn it over to you. Thank you so much for taking the time and thoughtfulness to present here.
Okay, thank you so much, Liz. Can you hear me okay? So thanks for having me. I feel really privileged to be here now. And little did we know back when, Liz, you reached out to me several months ago about this, that hopefully this topic will feel that much more relevant to people today. I can tell you, especially in Washington, suddenly local public health departments are on the tip of people's tongues more than ever, as we're on the tip of this iceberg with the COVID-19, et cetera. So I just want to tip my hat to my public health practice partners who are on the front lines of this. But what I'm going to talk about today is really give you some quick background to public health practice and their data needs, which is a lot about what we've been doing, or I've been doing in my research and with our team. And we'll talk about how we're standardizing data for decision making and generating evidence and some of the challenges and successes with that. And put it in a context. I'll be putting it all in the context of practice-based research and giving you a few examples and really a call to action to end us up there. So as we talk about practice-based research, when I talk about it, some of you may be schooled in community-based participatory research approaches. I think of this work as public health practice-based research as very similar to CBPR in some ways. But for me, my community is a community of practice. And it's those people in practice, public health practice, that are the ones that work with communities. But my community is really to serve them and their research needs so that they can work more effectively in communities. So the colleagues of mine and I refer to this as ensuring the co-production of new knowledge while also improving and expanding the implementation and impact of research findings in real-world settings. We've looked at the characteristics of CBPR and kind of mapped them to what we do in public health practice-based research and identified these characteristics that really resonate for us and our work, and puts this into the context for you, for others of you who really know CBPR, that for me, that's how my work is translational. We work hand in glove with the needs with public health practice partners, and meeting their needs for practice, and this research is conducted with and for them. So for me, I'm concerned about the evidence available to and used by, in particular, local public health departments, because local health departments have very pivotal positions in population-level health improvement and promoting health equity and reducing disparities in morbidity and mortality. And these leaders are expected to, quote, use and contribute to the evidence base for public health practice in improving health. And we should be expected to provide expertise within their communities regarding public health issues of significance. So these are the expectations and obligations of public health agencies and their personnel. I was one of them, as Liz mentioned. I didn't coin that term, but I like it, that term pracademic, and I was one of them, or consider myself one of them. But over 30% of local health department leaders are nurses, and that's something that has me all the more feel obliged as a translational nurse scientist to be committed to helping them fulfill these obligations that you see here. So backing up a little bit, this definition that I just referred to was established only in 2005. And in Washington State, and soon after the 2008 budget downturn, here at Washington State, I was hearing horror stories from my public health practice partners, public health leaders, who were making really super painful budget cutting decisions. Like a whole STD clinic at a local health department shutting its doors overnight to the public because of lack of funding and resources. So I got some funding from the Robert Wood Johnson Foundation at the time to do a study to find out how these decisions were being made, how they knew what to cut and where and what was going on. So I interviewed all the local health departments, in this case in Washington, and asked them about how they were going about this decision making. And all talked about wanting to use data and evidence. I never brought that up. They brought it up. They all talked about wanting to use data and evidence. But to a person, they talked about it not being available, We have no capacity to look at data. We had to lay off our, quote, data guy. I was always kind of curious who this mysterious, quote, data guy was. But in any case, they wanted to use data and evidence, but they weren't. They didn't have it. They didn't know how to use it. They didn't have the capacity. It wasn't available. And there are other dominant forces in this figure, this model that came out of that research. You see what the bigger circles are, sort of the more dominant forces around the outer edge. And those are important and influential. But the fact that they were not using data, and especially that they wanted to, but they couldn't or didn't, really disturbed me and them. And it disturbed all of us terribly, as this clearly could and did and would contribute to ineffective practice for performance and could exacerbate population level disparities. So that really put me on this path to this study that we call, it's now 10 years old. 10 years ago, we founded this study that we lovingly call FAST, Public Health Activities and Services Tracking. And we launched FAST as this sort of growing database, but it's really about facilitating the adoption and integration of standardized measures, developing tools to provide access to data and use data, existing data or new or growing data, new data for research that will generate evidence for public health practice. So that's what FAST is all about. But on top of this, when we talk about data for public health, one needs to understand that there are 28, in terms of local health departments in the country, there's roughly 2,800 of them, and there's roughly 2,800 different data systems. So they all vary tremendously. There's no real standard that exists for measuring public health activities, their expenditures. This lack of comparable data limits the extent to which policymakers, researchers, public health practitioners can really generate evidence and make decisions that improves health. It really undermines their effectiveness and our ability to do research that they need. So Liz mentioned this model that we developed. This didn't happen overnight, but over the years and based on our research and based on the push-pull implementation model developed by Deering and Kreuter, if you're familiar with that model, based on that and our research, we developed this FAST model in support of measure adoption, of standardized measure adoption. So here's our version of what we call the FAST model. It's described in a related paper, and I'll have a reference slide at the end. But this model has been built from our previous studies, and it depicts a virtuous cycle of observed factors necessary for integrating standardized public health measures into state and local systems. The three headings here in red are versions of these sort of three buckets that Deering and Kreuter describe. And all of these are very interrelated. So the practice and the research buckets have a lot to do with data and evidence needed for practice. But you can't do those together and have them interacting without some way of bridging this gap. That's the third bucket that Deering and Kreuter said was essential. And the bucket in our case really facilitates these interactions and relates to the capacity and the systems needed to help make this happen. So we've used this model to guide our efforts in working with public health leaders and community stakeholders and researchers to increase access to and consistent and high quality data for prevention practices, and also for making progress in maximizing the uptake of more standardized measures. When things aren't going well, or we've come up to hitches in our work and our research, we go back to our model and we ask ourselves what's missing, what have we forgotten, and it seems to be really meaningful. So on the need portion, or the practice side, the need for access to relevant data is often expressed by public health leaders and practitioners. they also would like to better be able to use the data that they do have. What public health leaders need, their challenges, their potential for the use of data are really critical parts to designing effective adoption strategies for data standardization. We've had many interviews with practice partners, and they always describe old data and reporting systems, lack of regular centralized systems. When the data are collected, it's often collected by several different agencies or state divisions, and they've got data quality problems. And they want to answer pressing problem questions such as opioid overdoses or immunization completeness rates. And now we're hearing from our practice partners, they want to know how much are we spending on preparedness or emergency response, because that's a really big area of spending all of a sudden. But these data are nowhere to be found for these folks in terms of understanding the degree of a problem or differences across agencies and how they spend in relationship to their marginalized populations or what have you. They've also talked about the lack of expertise in their agencies. That's this mysterious data guy that had to get laid off, or whoever this data guy is. In other words, they lack expertise quite often in doing sort of more sophisticated analysis, particularly in smaller agencies. And understanding how the generated data would be used for practice is also an important part of this process. So the two main purposes that have emerged from our work is over and over, they talk about they'd like to use data for discovering where the needs of their populations are, for determining priorities of public health services and programs, for monitoring activities over time, for quality improvement, looking at allocations of resources, et cetera. And secondly, they really want to be able to use data to communicate more effectively with stakeholders and decision makers, their boards of health, policymakers, elected officials, and very much also in the area of advocacy for resources or what have you. So FAST has gone from making use of existing data on the left to standardizing data prospectively. But I'm going to touch briefly on the left side first. And because these local health departments are often swimming in data, so you wonder, why don't these data get used more for reporting? But together we have done quite a bit, actually, together our team with public health practice partners in using existing administrative data, using a very collaborative approach with partners to make use of those data, and in 2.0 to develop more standardized data systems with them. But this has been, continuously a joint effort. And let me see if this works. Because as you see on the left-hand side there, this is sometimes those data. This is what they look like. And this is the actual picture of our closet here, and what some of those data look like. So that's many years of administrative data from one state and all of its local health departments. So working through that is a heavy lift. So in the generation of data, our primary activity has been to set up standardized public health measurement system and collect relevant data via it. So we look first with existing data and our partners, and I'll tell you a little bit about what we did with those data. And as a researcher, our FAST team has analyzed the data and interpreted the meaning from the data with our practice partners, and the direction of the data analysis is often driven by their demand and how it's used by practitioners, what they want to know. So it's really an iterative process in terms of listening to what they want out of the data and their input on the data analysis process and interpretation. And in terms of the research on the right-hand side there, we've also found that investigating research questions with practice, draws a lot more attention to the data, and improves the quality. So that's in part how it's iterative. So one thing we did early on with some of those existing data, including what was in that closet, that picture that I showed you with all the papers, was to do some rare matching of data across a few states and several years and on a few measures, all at the local county level and where we could. We called this our FAST finance suite of studies, since we ended up using financial data from local health departments over many, many years, and we could match up those data across some couple hundred health departments. So we ended up looking at, in this case, at maternal child health, at food safety, and communicable disease control, because that's where we could do some good matching. So we asked questions such as, do maternal child health expenditures by local health departments improve county level birth outcomes? And the answer was, ta-da, yes. We did some really, some complex modeling and pulled a lot of data together, et cetera. And this was a really exciting finding for folks that were in the midst of trying to substantiate and reduce the cuts to their maternal child health programs. Similarly with food safety, we looked at, or in environmental health and especially food safety, we looked at expenditures by health departments around food safety, and did they reduce enteric disease rates? And again, yes. And that too was really exciting to our food safety colleagues in local health departments who needed just that kind of evidence to talk to their policymakers, et cetera. We did the same with communicable disease control. With communicable disease control, we looked at STIs and immunization services, et cetera, but could not answer any of those questions around communicable disease control. That really fired me up too, because communicable disease control, as you see now more than ever right now with coronavirus, that's public health, that's the bread and butter of our state and local public health systems. And the data were too inadequate for us to really demonstrate relationships between spending in these areas or their amount of effort relative to these investments and related health outcomes. So these studies really were pulled immediately into policy making, et cetera, at the same time that this communicable disease control issue fired me up further, that we've got to get to more standardized data. And here's where that suite of studies had these implications. So this is really a proof of concept that when you've got adequate data, you can really say something about something that's really hard to study. The prevention activities are really hard to demonstrate their relationship to health outcomes. But we did it, and we could when we had enough years of data and they were adequately comparable. But the limitations of the data really limited what we could do, and really underscored the need for more standardized data, and also how important it was to work together with practice partners. So that last piece of the model is the data access piece. This part explains how we bridge that gap between research and practice. So even when we assume that we have enough data and the data are of high quality, it's still difficult or questionable how the practitioners can provide the data and access the data and use it for their purposes. So possible channels to make the data accessible and usable are a reporting tool, user-centered data visualization, infographics, training, et cetera. And we've used a number of these strategies going forward in a lot of our current work. In another project, we were funded to create a standardized uniform chart of account system for local health departments. I know that sounds really arcane, but we were asked to do this and it's gotten increasingly exciting as more and more health departments are eager to jump onto this standardized accounting system where they crosswalk their financial accounting data for expenditures and revenues to this structure. And the structure that you see here was developed hand in glove with our practice partners, with 20 state and local public health agencies as we put this together. I want you to take a close look at this far left column, capabilities. This one in particular was of great interest to them as they wanted us to make sure and be able to categorize these aspects of their capabilities, because this is the hardest thing to fund. They fund this through a lot of their funding for other programs, and then they scrape off a bit and put it into their capabilities, which is sort of your core infrastructure. And it's costly, but they have very little designated resources for it. So here's what some of that looks like. So far, we have about 100 agencies, state agencies participating, but there's fast and increasing interest. And you'll notice that this capabilities bar is one of the biggest. When you look at the individual subcategories, this is just subcategories of a few of those columns. Here's, again, capabilities. One of the biggest ones is organizational, core organizational competencies. And that's particularly, it represents things like information technology, data management, workforce development and training, a lot of things which you might think of are important right now in the event of an outbreak. They've been very eager to quantify this, even before the current crisis. Now you look at it, the same data from all our current participants from across the country, and you can see it broken out by basically smaller populations and larger populations. So for now, consider this rural and this urban. And again, you can see that actually the cost per capita of doing some of this work for rural agencies is much higher. So that's something people are really interested in being able to talk about as well, that we've got to pay close attention to rural areas. Again, new to this work has been of great interest is being able to look at, we've never been able to see this before until now, but how different funding sources are paying for different categories. These are the columns on the right here. And again, if you look at capabilities, that's a lot of, that includes preparedness and response, assessment, communication, these really core activities. It's largely local funded. And this disturbs me because on the one hand, local funding is good because it provides agencies more flexibility. But on the other hand, if it's dependent on local current tax base. So low-income areas or hard-hit regions might see this go down precipitously, and that means their basic core activities are going down as well, or their basic infrastructure. I could talk about one more project, again, about data, but I'll just flip through that really quickly. Again, it's about providing data for rural areas in our region and health departments to better address health equity and give them better data access. And we're developing dashboards. We're developing dashboards for our chart of accounts project too, and improving their capacity and using data for addressing disparities. And I want to lastly highlight this piece, and that is again in our model, part of the data access piece, that we're making the data more available to people in practice through dashboards that are very, very user-centered. So we've done a tremendous amount of really systematic data gathering about how they want to use data and look at it and interact with it, what they would use it for, and make sure, however we provide the data back to people, they can do without the data guy is kind of the key. So future research questions we have are how can we improve data quality, How can we help integrate data and visualizations into community engaged prioritization and planning? What type of training is needed? How can these data inform decision making? So can we predict investments needed? How does communicating more effectively with data impact resource allocations? Does better use of data improve public health performance? All sorts of questions are being generated out of this. And I want to bring this back to the context of nurses. So I really, some may not think of this may not be top of mind as nursing research, but to me it is. These are, nurses are the primary professionals in local health departments. More than a third of them are led by nurses. And just we as nursing researchers have obligations to just and effective systems. So Easterbrook and Brownson have referred to this call to action for public health professionals, public health researchers, but I would consider it a call to action for me and for us as researchers, that we use systems-based approaches with representation from the systems, collaborative processes that we work with our partners and considered in the context of those with whom we're working and to increase their own capacity at the same time. So I've got a reference list here, and here's my contact information. I'm going to hand it back to you, Liz, for questions.
So that was amazing. This is actually one of the first times I'm seeing this work collected in this way, Betty, and it is unbelievably impressive and utterly amazing. And I'm so grateful for you having shared it. I feel very inadequate. This is really tremendous work. I do want to open it up for questions from people. And we'll take some, and then if we have extra time and I could ask you to go back to that second study, I will. But I think this is so relevant, both, as you said, to what's going on today, and then also to other large programs that are looking to share their data without the data guy. So I'm going to open it up for questions from the group.
While we're waiting for a question, Liz, Betty, can you hear me?
Yeah, go ahead. Yeah.
I want to add that that I consider this as a nurse researcher, working, knowing about public health practice. That is what I know. That is what I want to advance. There are other researchers on our team who are researchers in finance, public policy, and two of the people on our team that are data visualization experts, they're nursing informaticians. So they themselves are nurse scientists as well. We have a number of nurses on our team, and one is a finance person as well. So this is a broad team, many of whom are nurse scientists that come at it from different directions.
That's fantastic. If I'm going to invite questions for another minute, and then if not, Betty, we can go back and learn a little bit more about those last two slides. But Chris, did you have a question? All right. So Betty, do you want to back up and just tell us a little bit more about the last two projects? And we'll let people think a little bit longer about it.
So so Share Northwest, Solutions in Health Analytics for Rural Equity in the Northwest is really a 5-year project funded by the Office of Minority Health. And our approach is to work with local and state public health leaders and tribes, and looking at how producing research and access to data that they can use more effectively to address health equity in their communities. And our Northwest region is very, very heavily rural and frontier. So frontier, if you don't know, is basically less than 7 people per square mile. And that's a lot of, especially Alaska. But the data, we have these 3 main goals around data and access and capacity building. So we've worked with our partners around the region, local public health partners around the region, to identify what are priority areas for addressing disparities, or promoting health equity in their areas. And we came up with 6, and we really settled on those through a variety of really systematic means, but they include addressing opioid abuse, obesity, oral health, tobacco, and a couple of others. And so with the data we're pulling together at the local level, local level data, representing local level data from in those areas. And those data are never enough. They are inadequate often for looking at health at different disparities, et cetera. But we're pulling together the data we have and what we can and what they want, and we're improving access to those data through really these user-centered dashboards. That part is led by nurse scientist Ugo Bachkonia, and our other chart of accounts project, the data visualization piece is being, user-centered design piece is being led by Dr. Beth Heikemper, also a nurse scientist. But these dashboards for the Share Northwest will have a lot built into them that will require folks to ask questions of themselves and others about the adequacy of the data for addressing disparities or promoting health equity, and what else they would need to do and find out and ask, et cetera. And then associated with that, we're looking at what kind of training people have access to that would be useful for them, online training, and what else is going to be needed. And we're also looking at related spin-off grants around, okay, so once people have these access to these data and dashboards and information in communities, does it in fact change how people engage around data in communities around decision making? Kind of going back to that original study I did right after the financial crisis. When people have better access to data for decision making, does it in fact change how they think about, in this case, addressing disparities? Are they more effective in doing so? Do they work differently with their communities and make different kinds of decisions or planning, prioritizing, et cetera? So I'd say that's it in a nutshell. I don't know, Liz, if you have other questions.
Well, I think it's just very relevant to the outreach that the CTSA, CTSCs, et cetera, are or should be doing. These are the types of questions that the CTSA Community Engagement Corps is, required to be asking and answering. And very often we don't have clear ideas like this in terms of community engagement. There's a lot that goes on with kind of offering education or engaging communities in different ways. But I think this type of engagement really empowers people, builds capacity for the people in the communities that we're able to reach through the CTSA programs to really improve their own health, which is really notable. I mean, I have close involvement with these types of corps, obviously, and there's lots of good work that's done, and I don't mean to minimize it, but this really takes the data piece to the next level. And I know that for some of the larger NIH studies, they're working very hard on that type of interactive dashboard, what people want and need and how they can how they can be their own data guy, as you said. So I think it's just all very relevant to the work that we're doing and trying to do, in that translational programming, in addition to being late stage translation itself. Right,
and the data visualization piece, of course, can build on a lot of good work done by other informaticians, you know, currently or, you know, still ongoing at Columbia are some real leaders in this area, for example. But this has really not been done with in public health or with public health practice people. And they're supposed to be the ones in communities that are delivering data to their communities and facilitating data-driven decision-making, et cetera. So this is interesting. Strangely, you wouldn't think it would be novel or new, but it is, and it's really been understudied and underdeveloped from the public health side. But we can take advantage of some of the methods we currently are taking advantage of, and expanding upon some of the methods for data visualization, user-centered design, et cetera. And I'm kind of speaking, this is my colleagues, Beth Heikemper and Uba Bachkonia, for example, who are really leading this. They're the ones with the expertise in this area, but we're all working together.
That's good. So maybe we'll give people, this can be a quiet group, but I want to give people one more opportunity, Betty, to ask you questions. And then we've unmuted everyone, so just be careful because we took you off mute, even if you think you're muted. And please, if you have any questions for Betty, that would be great. There, sometimes in follow-up, people also will contact you offline. So sure. That's another option, and we see that from time to time.
Sure.
Or very often. Go ahead. Do you have a question? Okay, then I think Betty, you're welcome to stay. We're going to make a few just announcements about upcoming conferences. Our regional conference is coming up, ENRS, so I just want to we're going to have just a short kind of business meeting about that. But Betty, thank you very, very, very much. This has been absolutely one of the best presentations that we've seen without question, and I so appreciate your work.
Great. Well, thank you very much. I was happy to be included.
Yeah, and feel free to stay. We're just going to talk about ENRS and upcoming conferences, which yours may be coming up as well. So for the people who are staying on the call, ENRS is coming up at the end of March in Boston. I don't know if we have an ENRS representative on the call. I certainly hope that we are able to take advantage of an in-person conference. I know a lot of universities are restricting travel right now, so I'm not sure if there's an update from anyone who's from ENRS. But we hope that we'll be able to take advantage of that conference in person, and if so, we'll set up a meeting. Actually, Chris, are you planning on setting up a meeting at ENRS? Oh.
You hear me?
Sorry, we had to. Yeah, now we can.
You can hear me. Okay. Yes, there's a luncheon on Thursday. I think it's from 12 to 1:30 for CTS members from our group. NYU is one of the places that has restricted travel. We're not allowed to travel domestically or internationally for any work-related business. That's not exactly true at the nursing school, but because my appointment's also at the medical school, I have to follow their rules. So I'm not going to be there, and it's on the calendar.
Okay. Yeah, I don't know. I think.
Are you allowed?
So you're not going to.
Are you allowed to travel?
No, we're not. No, there's no domestic travel. There's no travel for schools at all. You know, for work-related travel.
My name is Julian Johnson, and I will be attending a conference in Birmingham through the Resource Centers for Minority Aging at the end of the month. And I already made a hotel reservation and they've advised me to cancel that so I can get the conference amount.
They advised you to cancel it. I'm sorry, say it again.
Confirmation number.
You're asking about a refund for the conference?
Nope, I'm calling you to cancel.
I don't know the
Okay.
I don't know the answer. That's an ENRS question. Are there a lot of people on the call who now have restricted travel?
Yes, it is.
Anybody? Anybody else have restricted travel? Just
Oh,
Columbia and
okay.
NYU and
All
Hunter?
right. Thank you very much. Okay.
Yeah, well, I think
Can I
most
make a new
people,
one then?
if they don't have it, Chris, by March,
Right.
they will. Hopefully, it'll be lifted again. But I couldn't hear what the last caller was saying. Is she saying that
Well,
she was told to
there's a message
cancel
from
her
you that
ENRS?
says call them. And then I saw that you were with UAB, but maybe you're not. But Hilton, yeah.
I think she's talking to somebody. I think we can. Yeah, I think she's
Got
talking
it.
to somebody else. So so Chris, again, I'm sorry for the minutes. For those attending ENRS,
Okay, Margaret
the lunch
McCabe.
on Thursday.
Margaret McCabe from
Okay.
Children's Hospital in Philadelphia had agreed to
It
run that luncheon,
is.
but I suspect that she's not going to be allowed to travel either.
Okay.
I arrive on
All
March
right.
I guess
30th
I'll ask her.
and
Thank you
leave
very
on
much for that.
Thursday, the 2nd of April.
I think she doesn't realize that she's not on mute. So with that, I think I'm not sure what the best way to proceed
The
then
Resource
is
Centers for
in
Minority
terms of this
Aging
call.
is UCLA.
I actually
Maybe
have to
David.
get off, Liz, so I'm going to say
Yeah.
goodbye. And everybody who
So we
can
thank
do
you
it,
all for
have a good
attending, and I think, yeah. And thank you very much, Betty, for the presentation, and we will see you all at the end of the month for those able to travel in Boston. Okay, thank you, everyone.
Thank you.
Thank you.